Thank you, Rahul, for that excellent talk and a good introduction on ALK mutation in lung cancer. And like you said, we have indeed come a long way from where things were about a decade ago, where ALK was just a molecular alteration, but now this field is becoming more and more crowded. So only a small percentage of lung cancer patients have ALK translocation, but the number of drugs are growing. And you've given an excellent talk on the role of alectinib, and I'm going to talk on lorlatinib, and subsequently Dr. Vamshi is going to talk on ceritinib, all looking at first-line treatment. So first-line treatment in ALK translocation has become a very crowded field. And I think at some level we will need to sit and decide as to which sequencing to be used. But this, Dr. Rahul already shown that about 7% of the patients tend to have ALK translocation, which is a fair number of patients given that lung cancer is one of the most commonest cancers we see in our clinic. So ALK development has pretty much started less than 10 years ago. I think in 2017 was the discovery of the translocation, and the first drug was the crizotinib that was approved in 2012, which is just about shy of 10 years ago. And since then, there have been very many drugs that have come along. So crizotinib was the first generation drug. Subsequently, second generation ALK inhibitors came into being, which is ceritinib and alectinib. Alectinib we've just heard about, and ceritinib we're going to hear about next. And now we are already talking about third generation drugs, which is lorlatinib, which is the topic for discussion right now. And most recently, 2021, US FDA approved lorlatinib for use in frontline ALK translocated lung cancer. There are obviously molecular differences between first, second, and third generation. The first generation being crizotinib, second generation ceritinib, alectinib. Brigatinib is a second generation which is not accessible to us, is not available in India, and the third generation is lorlatinib. But more importantly, as we move further from the generation, we see the potency gets better, the activity against the mutation itself gets better, and you have better CNS penetration and activity going forward. Obviously, this was the first trial looking at the role of crizotinib in 2 patients who had ALK translocation, and you could see the median progression-free survival was about 9 months. Now, you don't see that with chemotherapy. With the average median progression-free survival of chemotherapy is about 4 to 6 months, and this almost doubled it. And this kind of heralded the growth of ALK inhibitors in lung cancer. We've already recently just seen these curves where crizotinib was compared with chemotherapy, both in second line as well as first line, and we see impressive progression-free survival benefit. And then subsequently, obviously, the role of ceritinib, the role of brigatinib, the role of alectinib. So various studies have been done, subsequently increasing the progression-free survival at every point. The highest so far being with alectinib, which was 35 months, or just shy of 35 months. Brigatinib with crizotinib was 24 months, and ceritinib versus chemotherapy was 16 months, and 10 months with crizotinib. So you have 10 months, 16 months, 34 months. So subsequently, with every trial, with every new generation, the progression-free survival keeps getting better and better. Lorlatinib was a rationally designed drug to address the unmet need, particularly with regards to dealing with acquired resistance to ALK TKIs, as well as good penetration and entry into the blood-brain barrier. Before we look at the main data, I think we want to show that we have our own Indian data from TMC. Looking at the role of lorlatinib in TMC, they give lorlatinib to 41 patients with a median follow-up of 16 months and showed a disease control rate of 73%. A median progression-free survival was 16 months and overall survival was 23 months. And only 3 patients needed dose reduction. So reasonably well tolerated with good clinical benefit. Now, this is our own in-house study by Kumar Prabhash and team. So the thing about ALK translocation is that with every subsequent progression, so you have an ALK translocation, you give them a drug, and then they progress, and then you give another drug. So every subsequent progression, you get more and more ALK resistance that come into being. So the more powerful drugs should ideally be used earlier on. So in this, if you look at a specimen, you have crizotinib, and then they develop resistance to crizotinib, and then move to brigatinib, and they develop resistance to brigatinib, and then move to lorlatinib. By the time they've gone to lorlatinib, they have had multiple resistance all molecular alteration. We know this data that the PFS of lorlatinib changes depending upon the lines of treatment that have been given before. So the earlier you use the lorlatinib, the longer is the PFS. So if you look at PFS post third line TKI is 6.5 months, second line is 11.2 months, and 2 prior TKIs is not reached based on these data that has been shown. So what we want to do is looking at use of pan-inhibitory agents upfront to reduce the development of resistance, and obviously the better drugs should be used upfront. The more stronger drugs which have wider ALK inhibition should probably be used upfront, which is what lorlatinib was designed for. So the most important trial for lorlatinib was the phase 3 multi-center randomized trial called the CROWN study. This study included all patients with stage 3B and 4 ALK translocated non-small cell lung cancer. This was first-line treatment, so the patient should not have had any prior systemic therapy. Good performance status, patients had to have asymptomatic, treated or untreated CNS mets were permitted. More than one extracranial measurable target lesion should have been there with no prior radiation. Patients were randomized to lorlatinib versus crizotinib into 1:1 randomization, and the stratification factor was the presence of brain mets as well as ethnicity. The primary endpoint was progression-free survival with various other secondary endpoints. So you had 296 patients randomized in the study, 149 to lorlatinib and 147 to crizotinib. They were reasonably well balanced across both the groups, and particularly if you look at brain metastasis as baseline, you had about 30%, about 26-27% in each arm. So this was the primary endpoint. You look at the progression-free survival was not reached in the lorlatinib arm, and 9.3 months in the crizotinib arm. And you look at the hazard ratio, 0.28. That is as good as it gets. 0.28, statistically significant with a confidence interval of 0.19 to 0.41. And you look at a 12-month progression-free rate of 78% in the lorlatinib versus only 39% in the crizotinib. So excellent data, excellent hazard ratios all across. And when you look at the PFS by the investigator, you see a similar picture with a hazard ratio of again 0.21, highly statistically significant. The curves are wide apart. Look at the forest plot. Again, everything is in favor of lorlatinib compared to crizotinib, particularly when you look at ethnic origin, Asian and non-Asian, both of them benefit from it, and this is irrespective of their smoking status or age. Looking at the overall response rates, again, more patients in the lorlatinib arm responded to treatment as opposed to crizotinib arm. But more importantly, I think when you look at the median time to response was 1.8 months. So the time to response was pretty quick in both the arms. When you look at the brain mets intracranial overall response, there were more patients who responded with lorlatinib, which is 66%, versus crizotinib in those patients with measurable or non-measurable brain metastasis as baseline. And when you look at only measurable brain mets at baseline, 82% in lorlatinib arm responded compared to only 23% in the crizotinib arm. Again, highly statistically significant. Duration of response was not evaluable in the lorlatinib arm versus 9.4 months in the crizotinib. So excellent overall intracranial activity. And this was the CNS progression-free curves. Lorlatinib is flat right on top versus crizotinib. Again, lorlatinib not evaluable since it was not reached versus 16 months in the crizotinib. You look at the hazard ratio, 0.07. I mean, I don't think so we get better hazard ratios than these. Overall survival data is not mature enough. Both of them were not evaluable because both of them did not meet the endpoint at the time of this presentation. Hazard ratio of 0.72 with overlapping confidence intervals. Safety, again, there was slightly more toxicity in the lorlatinib arm versus crizotinib arm, but nothing untoward about. Most of the toxicity in lorlatinib we know are more biochemical than physical, which we'll look at. So if you look at the lorlatinib toxicity, it is more hypercholesterolemia, triglyceridemia, some amount of edema and weight gain, but nothing unexpected, nothing that we don't know about, nothing that would preclude a significant dose reduction in our patients. Change of baseline from the global quality of life scores, better improvement with lorlatinib as opposed to crizotinib, but especially after the first few months of starting treatment. So overall, lorlatinib resulted in a statistically significant longer PFS compared to crizotinib, better quality of life, and better intracranial response rates were seen. So I do feel that we should start looking at using lorlatinib in the first-line therapy for all our patients who've got IL translocation non-small cell lung cancer. Comparison with the first-line studies, again, this is not meant for a scientific comparison, but just to give you a brief idea of all the ALK inhibitor studies in first line. We've already heard about the ALK study. And we look at the CROWN study, you look at the hazard ratios. Hazard ratio in lorlatinib was 0.28. And a CNS response rate was 71%. So I think that is something to take home. When we start looking at a systemic review network analysis, again, lorlatinib trumps the other drugs such as brigatinib, alectinib, or in patients who've been previously untreated with ALK inhibitors or chemotherapy. Again, but network analysis have its own caveats, something we have to keep in mind. NCCN guidelines, the most recent, prefers lorlatinib as a category 1 along with brigatinib and alectinib. So they don't discriminate which one to use. All of the three have category 1 recommendation from NCCN. So we saw this curve from Dr. Rahul Sood in terms of how we've come in terms of ALK inhibition, but we've just put in the last line for alectinib. For just below alectinib, we've put in lorlatinib. Progression-free survival is currently not reached, but hazard ratio of 0.28. So only time will tell with further follow-up whether the progression-free survival will be significantly longer than that of alectinib and second-line lorlatinib combined to trump all of the above. So, but what this clearly tells us that over the past 10 years, we've come a long way in terms of improvement in progression-free survival for our patients with subsequent generations of ALK inhibition. That is it from me. Thank you very much.